Well, hello everyone, and thank you for being on the Rheumatology 101 video channel. I'm Dr. Amig, your friendly rheumatologist, and yes, I am French, and that's why I cannot hide my accent. All right, so today I would like to talk to you about why some certain rheumatoid arthritis are difficult to treat. I'm going to talk about rheumatoid arthritis, but I could literally be talking about any sort of inflammatory arthritis. So it is very important that you continue to listen, even if you have psoriatic arthritis, ankylosing spondylitis, or gout, or pseudo-gout, or anything like this, okay? So this is important for me. So the first thing that we're going to go over is why potentially you have difficult to treat rheumatoid arthritis. And we're going to go over the reasons for this. Then we're going to go over what we can do for this, okay? All right, so the first thing first is how you define a remission in rheumatoid arthritis. So, and before that, I want to talk about the fact that when we say difficult to treat rheumatoid arthritis, that is actually a medical term. It's not that you're difficult. You're not difficult. No patient is ever difficult, okay? So that's really important. It's your condition that is not as easy peasy when it comes to treatment. And it doesn't mean anything else than we just have to scratch our head and figure it out for you, okay? That is our job, and that is why you're paying us. Okay, so this term of difficult to treat, just realize that it's a scientific word for when rheumatologists are talking to each other, which is, when you're basically having to need, more than one round of biologic, maybe another 2 round, another third round, etc. Okay, so that's really important. The first thing is to realize what disease remission is. So there is an also definition for this, which is that you have no more joint pain, you have no more morning stiffness, and you have no more swelling of the joints, okay? If you achieve all of this, you are considered in disease remission, all right? So that's important. How do you make that assessment? Is really you are going to your rheumatologist assess, touches your joint, looks at them, and see if you have any tender of the joint, and if you have any morning, if you have any swelling or synovitis, inflammation of the synovium of your joint, okay? And then we also ask you how much morning stiffness you have. We aim in rheumatology for complete remission. Complete remission. So if you do not have complete remission, we're not happy. Or at least I can tell you, we should not be happy. And I'm not happy if you don't have full remission, because my job is to get you to a full remission. Full remission does not mean that you don't have medication. Full remission just means that you've achieved disease remission where your disease does not bother you. And the only thing that's going to happen is that you're thinking of your disease. The only time you're thinking of your disease is when you need to take your medication. Okay? That's very important. Now, why are some rheumatoid arthritis more difficult to treat than others? Well, there's a couple of things. I don't have all of the answers. And of course, it's very dependent on the patient and who we have in front of us. However, there are a couple of things that we have to take into account. So number one, not everyone is going to respond to each of those drugs that we have, okay? So we know that we say it's between 1/3 and 2/3 of the population is going to respond to the first line, which is usually methotrexate, okay? But, the other people are not responding to methotrexate, and that's when we usually offer a biologic per the standard guidelines. We offer biologic. They are very well tolerated. They are beautiful treatments, and we can talk about this one day. And basically, we try to put you in disease remission thanks to that. If after 3 months, you are not in disease remission with the treatment, then we go to another biologic, and then another biologic, and we rotate like this every 3 months. Here is what I have seen happen in my practice. Number one is that maybe you have put your patient in disease remission, but they don't necessarily realize it because they still have pain, but the pain is not related to the rheumatoid arthritis. So we have to realize that rheumatoid arthritis can be associated with what we call osteoarthritis, which is what some people call wear and tear. But the truth is that rheumatoid arthritis, if it has been going on for a while, and if it is a destructive type of rheumatoid arthritis, you may have what we call osteoarthritis as a secondary complication of rheumatoid arthritis. That pain cannot really do much about this, and definitely not with immunosuppression. And so you may still have pain from your rheumatoid arthritis, but it's not the inflammatory rheumatoid arthritis that you have. And this is, by the way, call to action is make sure that you see someone as fast as possible when you're diagnosed with rheumatoid arthritis, because the earlier you take care of your rheumatoid arthritis and you put it in remission, the less chance of any sort of a complication you have, okay? So that's the first one. So first one is maybe you have some other type of condition that are causing you joint pain. So osteoarthritis is one of them. Then there's also the fact that you can have what we call fibromyalgia or small fibers neuropathy. That can also cause pain. Usually this is a pain that's all over your body and you're touching your skin, like deep skin pain feelings, okay? So that is very common, and that is not treated the same way than we treat rheumatoid arthritis. So we have to address this, and we have to acknowledge and to then treat this, okay? And then you can have just basically ongoing pain. And that is, I think, the one that's the most difficult, is that if you have been, for example, taking medication forever for pain, and suddenly we're trying to decrease it. So for example, let's say someone, well-intended, but honestly, I would argue that it's not a good idea, has given you prednisone. Let's say you have waited, they saw that you have to wait like 3 months to see a rheumatologist, which is awful. Well, they don't want to see you in pain, so they're giving you prednisone. Not a good idea. But at the same time, I completely understand. The good idea is to see a rheumatologist as fast as possible, but sometimes it's not possible. And so, yeah, maybe your primary care physician feels that that's the only way that they have to make you feel better. So they give you this prednisone. The problem is that then you develop this dependence to prednisone. And as you're trying to decrease it, if you're decreasing it a little too fast, then you can have body pain. And you can actually have also joint pain, and that will cause some joint pain. And then you think that you're not in remission, even though maybe your rheumatoid arthritis is in remission. It's just you don't see it, right? And so that's like some of them. And then rheumatoid arthritis can also be associated with pseudo-gout, right? So usually we say that it's rare that it's associated with gout. I would say that I have seen it, positive, erosive rheumatoid arthritis, typical, and gout. So that does happen, but in general, we say that it's either gout or rheumatoid arthritis. But pseudo-gout is definitely something that we see. So gout is crystal of uric acid. Pseudo-gout is crystal of calcium, basically, if you want to say. And so they are very different, but they can present sort of the same with this inflammatory, really painful joints, swollen, etc. And the pseudo-gout is not treated the same way. And then you're going to treat rheumatoid arthritis. So you've got to see this, okay? And then you also have a chronic fatigue, depression, and so on. So those are like really important to realize that, it might not be that your rheumatoid arthritis is not well treated. It might be that there are other things that are going on, but because of time, maybe your rheumatologist is not taking enough time, or maybe it has nothing to do with your rheumatologist. Your rheumatologist is like, no, you're doing great. Thank you. Bye. See you in 6 months. And they don't take the time to assess, well, what's going on other than this, right? Then there is this question of, that you may not tolerate the drug. And this is where I love my practice, because we spend a lot of time working on mindset and making sure, like in this holistic approach, that every single drug is really something that our patients really want to try and are really giving all of them to it, right? There's no point for me in my practice to offer a medication if it's not going to be taken, or if my patient is afraid of it. And so I take a long time to really make sure that we understand medication, we understand what they're going to do, we understand why I'm offering them. I would not offer any medication that I would not take personally, right? If I were to have those symptoms and the manifestation. But I think that there is a lot of things where, we see a patient that develop some side effects for the first, to the first medication, and side effect to the second medication, side effects to the third medication. And so we have to wonder, okay, what's going on here? And then the problem is that because you've had side effects of those 3 medications, now you're afraid of any new medication. And so I think that that's really where working with someone that you can have on the phone or have on, via text, etc., that's actually really valuable. But that is definitely some of those patients that some other rheumatologists would call difficult to treat rheumatoid arthritis. All of this is also something that can be seen in psoriatic arthritis and so on, all right? So that's really important when I say difficult to treat conditions that are inflammatory. So in summary, when you feel that you may have, or someone that you love may have, a difficult to treat rheumatoid arthritis, don't lose hope, okay? There's tons of hope. Number one, we have amazing treatment. We have amazing lifestyle modification, and we know that they work, right? So that's number one. So we know we can get you to full disease remission. That's the job that we have as your rheumatologist. Number two is, let's take the time to make sure that what you have pain from is indeed your rheumatologic condition. Is there a possibility that maybe there's something else? Maybe we have misdiagnosed you and you never had rheumatoid arthritis, right? That's also possible. Let's also work with you and make sure that you understand all of the medication you are taking. And that's really what we're talking about. All right. I hope this was valuable. I hope you learned a lot. I talk fast. Hopefully that's not too fast. Let me know if it is too fast, and I will try to make it better. And as always, I'm sharing the fact that currently we are into like 10 months of this practice of mine that's direct and concierge care rheumatology in Denver, Colorado. There's a lot of interest, and I'm loving what I do, and I'm so grateful, and I don't take this for granted, and I'm so grateful to do the job that I do, to do it with the people that I'm doing it for. Currently, we are taking patients. I would love to take care of you. I would love to get you to remission, and I would love to make sure that you enjoy this journey and you have someone on your path with you. I would love to be that person for you. I would love to guide you through disease remission. My cell phone, all of the contacts are there. You would have my cell phone if you're one of my patients. So that's just, one of those things. And we're currently accepting new patients. And so I would love to see you. Contact us at info@unabridgedmd.com. And if you need a discovery call, I currently offer some of those, and it's absolutely free. So no problem. Just, we do not take insurance. We work with them, but we do not take them when it comes to my encounters with my patients. All right. I hope to see you soon, and take care. Until then, bye-bye.